Okay, this lecture is going to be on the musculoskeletal and neurosensory systems. Okie dokie. So, this is chapter 31. So this exam includes muscles, joints, range of motion, mental status, cranial nerves, and motor and sensory function. Alright, so examination of the musculoskeletal system includes assessing both its structure and function. Assessment involves examining each joint, muscle, and the surrounding tissues bilaterally and comparing them for symmetry. We're going to be using the techniques of inspection and palpation to assess the musculoskeletal system. So, some of the equipment we will use would be a tape measure and a cover for privacy. So, you assess their gait, which is their manner or style of walking. You can assess their alignment, which is position of the joints, tendons, muscles, and ligaments while standing, lying, or sitting. So you would look at like their scapula and hips to see if they're in line with each other. Looking at their symmetry of muscle mass. Looking at the muscle tone, which is a state of balanced muscle tension, allowing one to maintain positions such as sitting or standing. Range of motion, which is the maximum amount of movement of a joint. Sagittal would be left to right, transverse is side to side, and frontal is front to back. Any involuntary movements, any indications of inflammation such as redness, swelling, warmth, tenderness, loss of function, and if they have any gross deformities. So expected range of movement for joints, we have flexion. That decreases the angle between two adjacent bones. We have extension, which increases the angle between two adjacent bones. Hyperextension, which is movement of the body part beyond its normal extended position. Supination, movement of a body part so the ventral or front surface faces up. So it would be like our palm facing up, that's supine. Pronation, so that the front surface faces down. So supination, front is facing up. So that is, if we're laying down, for example, our palms are face down and the front of our hand is face up. That would be supination. Pronation is when we flip it. Abduction. You want to think of abducting something or taking something away. So that would be moving the extremity away from the midline. Adduction is when you're adding something. So, for example, your arm crosses over your midline. That would be adduction. Dorsiflexion is flexing the foot and toes upward. So that would be like you think, dorsiflexion. So that's what we consider like flexing, and then plantar flexion is pointing. So remember, dorsiflexion is flexing, plantar flexion is pointing the toes. So that's bending the foot and toes downward. Eversion is turning a body part away from midline. Inversion is turning a body part toward midline. So for example, with our hand, this would be inversion. Well, it's hard to do your hand. Inversion, eversion. External rotation is rotating a joint outward, and internal rotation is rotating a joint inward. I'm going to do the performance test in a separate video, and then I can show you flexion, extension, hyperextension, and all that. So for review of systems, you can ask if they have any falls, any pain, ability to take care of self, any problems that limit activity, if they exercise or participate in any sports on a regular basis. For postmenopausal women, you can ask what their maximum height was and if they're taking any calcium supplements, because that has to do with bone. So when we start inspection, we want to observe and compare both sides of the body for symmetry. Height, you measure for a comparison over time. Gradual height loss is common in as people age. Posture, you observe when the client is unaware. So if you're just having a conversation, you can observe their posture. Don't tell them because they might change it. Expected finding would be that their client, their head is erect, both shoulders and hips at equal heights bilaterally. So they're not like this, and their hips aren't like that either. So the expected curvature, think about our spine and how it goes. So first it goes convex and then concave, which is expected. So we have the concave cervical spine, so that's up here, and then it goes out convex for the thoracic spine, and then it goes in concave for lumbar spine, and then out convex for sacral spine. So it kind of goes back and forth. Unexpected findings would be kyphosis, which is kyphosis, and that is exaggerated curvature of the thoracic spine. So that is the upper part. So when you see the people hunched over, that is kyphosis. Now, lordosis is exaggerated curvature of the lumbar spine. So that's the lower back. That can be common in toddler years or during pregnancy. So that is usually convex, so exaggerated. They might be kind of leaning back and you see that go in more. So you think, of a pregnant woman, she might be leaning back because she has so much extra weight in her belly. And then scoliosis is exaggerated lateral curvature. So that you see looking straight on their back, there is an exaggerated curve of the spinal column vertebrae. All right, so kyphosis, exaggerated of the thoracic spine. So that's in the top part, seen in older adults. Lordosis is curvature of the lumbar spine, so that's the lower back. You can think lordosis, lumbar spine, lower back. Common during toddler years and pregnancy. And then scoliosis is exaggerated lateral curvature. So, inspecting and palpating, the expected equal range of motion in joints bilaterally. You can assess passive range of motion by moving the client's joints through all the movements. So don't move a joint if they're having any pain or if there's any resistance. Don't force anything. You're going to assess the joints for warmth, any inflammation, edema, stiffness, crepitus, deformities, tenderness, all the usual stuff, limitations, instability. We usually assess the TMJ joint, the shoulders, the elbows, the wrists, the hands, the spine, the hips, the knees, the ankles, and the feet. So muscles should be firm, symmetric, equal strength bilaterally. The dominant side might be slightly larger, but it's usually less than 1 centimeter difference of the muscle. So size variations. Hypertrophy, which is, we know is enlargement of the muscle due to strengthening. And atrophy, which is a decreased muscle size due to disuse, and it might feel soft and boggy. So during range of movement, you want to assess tone, slight resistance of the muscles during relaxation. Assess the strength by asking the client to push or pull against resistance. So for an example, if I have my arm out and I'm going to try to push the forearm up, assessing for the elbow, if they have their arm straight out and I'm going to try to pull it up and they can keep their arm straight, they usually have good muscle tone. And don't forget to do the other side. During the performance test, I believe we're doing one side, but when you're actually doing it, you want to do one side and then the other side so you get the symmetry. Assess for any muscle tremors, expected finding would be strength is equal or slightly stronger on the dominant side. So you want to inspect and palpate from the back for any lateral deviations or scoliosis. So you have the client bend at the waist with their arms reaching down for their toes. You can inspect and palpate down the spine using your thumb and forefinger, like this. And then you can do it again while they're standing. And expected would be that there's no tenderness and that the vertebrae are in midline. Vertebra. I don't know why I said it like that. Okay. That is musculoskeletal. Now we're going to move on to neurosensory. So I'm also going to open up this lecture, cranial nerves. Okay, so the neurological screening examination can evaluate major indicators of neurological function and assist with recognition of areas of dysfunction. So you can integrate the neurological system with other assessments. So parts of the exam include mental status to test cerebral function, sensory function, reflexes. So some of this goes back and forth with the performance test. So this would be like the Snellen and Raubaum eye charts, the aromatic substances if they might have anosmia, the tongue blades, pen light, sugar and salt for taste, which we're not going to do in class, tuning fork, reflex hammer, cotton balls, pencil, water, paper clips, a key. So in review of systems, we can ask them if they're having any dizziness, headache, seizure, pain, weakness, numbness, tremors, tingling, and if so, where they're having those things. So we'll always start with inspection. So to inspect for mental status, we're going to do... Alright, so there can be a couple different things. So you just observe their level of consciousness and observe their behavior. So what would be expected would be alert, which means the client is responsive and able to open their eyes and answer a question spontaneously and appropriately. Lethargic, the client is able to open his eyes and respond but is drowsy and is falling asleep readily. Obtunded, which is obtunded, obtunded. That's when the client responds to light shaking, but can be confused and slow to respond. So they might be kind of dozing off and you shake them and they wake up. That is obtunded. Stuporous, think of the word stupor. That is when the client requires painful stimuli, such as pinning a tendon or rubbing the sternum, with your fist. To achieve a brief response. The client may not be able to respond verbally. And then there's comatose, no response to repeated painful stimuli. Abnormal posture. In clients that are comatose include, DECORTICATE, decorticate rigidity. That is flexion and internal rotation of the upper extremity joints and legs. And then there is decerebrate rigidity, DECEREBRATE rigidity, which is neck and elbow extension and wrists and fingers flexed. So I guess when you try to remember those, the decerebrate, I don't know how to say that. Decerebrate rigidity. It has CERE in it, so think of like the cerebellum, like head, so neck and elbow extension. Okie dokie. Assess their appearance by observing hygiene and grooming, clothing of choice. Expected findings: the client is clean, dressed appropriately. Assess their mood, inspecting any mannerisms or actions during the interaction. Expected would be the client makes eye contact and emotions correspond with the conversation and stimulation. And situation. Assess for any cognitive or intellectual processes. You can ask the client to repeat a set of numbers or list objects to assess their memory, both recent and remote. So you can say, okay, repeat 4792. And then they would say 4792. So that would be recent, is repeating immediately. And then remote would be asking the client to state their birthday, or if you know their mother's maiden name, ask them their mother's maiden name. That's remote. So remote memory, that's farther. Recent is recent. Okie dokie. Just think of, oh, I remotely remember that. It's, happened a little while ago. You gotta think about it for a second. All right, so you can assess their level of knowledge. You can ask the client what he knows about their current hospitalization or illness. Ability of calculation, which is you can ask the client to count backwards from 100 by a series of sevens. So 100, and then they have to do the math. Okay, 93, and then they go down and down to see if they can calculate that in their head. All right, so abstract thinking. Ask the client the interpretation of a cliche, such as a bird in the hand is worth two in the bush. I've actually never heard that cliche, but I guess you could ask, what is hitting two birds with one stone? I know that one. So that's abstract thinking. Insight, you can perform an objective assessment for their perception of their own illness. Judgment, you can ask the client a solution to a specific dilemma. What would you do if you locked your keys in the car? Judgment. Thought process, which would mean noting the processing differences, such as a rapid change of topic, which is called the flight of ideas, and the use of nonsense words such as hip-snippety. Okay, that's interesting. Thought process. Noting processing differences. So if they rapidly change the topic, they might have flight of ideas. Or if they use nonsense words, such as hip-snippety, for example, I guess. Alright, thought content. You can note the presence of any delusions, hallucinations, or other ideas that the client presents during the interview. You can expect the language and speech, such as quality, quantity, volume. They should be articulate, and the responses should be meaningful and appropriate. Alright. Some standardized screening tools. We have the mini mental state examination. That orients them to time and place, attention and calculation of counting backwards by sevens, recalling objects, language, including naming of objects, following commands, ability to write, reading. Also, we have the Glasgow Coma Scale. Glasgow Coma Scale to obtain a baseline assessment of the level of consciousness of the patient, and you can use it for an ongoing assessment. It looks at eye, verbal, and motor responses. The highest value is 15, which would indicate full consciousness, and that is the Glasgow Coma Scale. All right. So now moving on to the motor function. So some of this kind of goes into our performance test. So you would assess coordination by asking the clients to extend his arms and rapidly touch his nose, alternating hands, and then doing it with his eyes closed. You can assess gait when the client's unaware. Expected would be steady, smooth, and coordinated. You can assess balance doing the Romberg test, which is when you have the client stand with their feet and arms together at the sides and eyes closed for a minimum of about 5 seconds, and they should stand without swaying, but you want to make sure you're next to them just in case. You can do tandem or heel-to-toe walking. Expected would be the client walks in a straight line without losing their balance. Muscle strength. Ask them to push or pull against resistance. Expected that it's equal or slightly stronger on the dominant side of the body. Alright, so on to sensory function. That's the sharp and dull objects, asking them to say sharp or dull. You can use like a paper clip, having their eyes closed, and you just want to go, you don't want to just go sharp, dull, you want to mix it up so they can't guess. Assessing light touch on the skin with a cotton ball. You can do the assessing the vibration with a tuning fork on the skin, and they can also do assessing temperature if you have 2 test tubes, one with warm water, one with cold water. You can assess discrimination by using the 2-point discrimination, which is using an open paper clip to determine the smallest distance between 2 points, at which the client can still feel the 2 points on the skin and not just one. So that's like when you take, the open paper clip, so like a little sharp side, and you put it on your skin, and they might feel, okay, 2 points, and as they get closer, when they feel just 1 point and not 2. The minimal distance will vary by body part. Then stereognosis, which is placing a familiar object such as a key or a cotton ball in the client's hand and asking them to identify it. And then there's graphesthesia. That is when you trace the number on the client's hand with like a blunt end of a pencil and ask them to identify it. Trying to think how we can remember that. Graphesthesia, I guess, just like pretending that their hand is graph paper. I think you use graph paper in math, and you might be writing a number on their hand. Stereognosis, that's when you put the familiar object in their hand. Guess you just have to remember that one. I can't think of why you would put stereo in your hand for that. So, anyways, be moving on to deep tendon reflexes. So you're going to use the reflex hammer to assess these bilaterally and compare for symmetry. So for the biceps, you're going to flex your arm at a 45-degree angle. You're going to place the thumb on the tendon in the antecubital fossa and strike your own thumb with the reflex hammer. Your expected response would be flexion of the elbow. Brachioradialis. Rest your forearm on the examiner's forearm with the wrist slightly pronated. Strike the tendon about 5 centimeters above the wrist. Expected response will be pronation of the forearm and flexion of the elbow. Triceps, you can support the upper arm with the arm hanging at a 90-degree angle. You strike the tendon above the elbow. Expected response would be extension of the elbow, so it would be this way. Achilles, flex the heel and strike the tendon above the heel. Expected response would be plantar flexion of the foot, which is pointing. For Achilles, you flex the knee, dorsiflex the foot. So you can have the client lay down with their feet straight, foot flexed, and strike the tendon above the heel, the Achilles, and you would expect it to point. Patella, we know, striking the dangling leg right below the knee, the tendon. Remember, you always want to strike the tendon and not bone for the deep tendon reflexes. So the deep tendon reflexes grades would be 0 is no response, 1 plus diminished, 2 plus expected, 3 plus more brisk than average, 4 plus very brisk. So expected findings with some aging. The musculoskeletal system, usually may have a reduced muscle mass, declines in speed, strength, and resistance to fatigue, decreased reaction time, decreased coordination. They might have osteoporosis, which is fragility of the bones and loss of bone mass and height. That's when you can see that curvature. Remember, that one's kyphosis when you see it in an older person. Greater risk of fractures, limited to range of motion. They might have flexed elbows, hips, and knees. Thinning of the vertebral discs, again, kyphosis. That can, if the vertebral discs are thinning, they might have decreased height, wider stance, altering their posture. So for the neurological system, they might have some short-term memory decline, diminished slow reflex and motor responses, altered vibration, position, hearing, vision, smell, and deep pain, temperature and sensation, slower fine finger movement, usually no change in superficial pain or light touch sensation. Might have a decline in mental function related to any cognitive stimulation. Less cognitive stimulation or more solitude. They might have fewer brain cells, smaller brain volume, deteriorating nerve cells, fewer neurotransmitters. If they're having infections, they might have any kind of delirium, and they have a greater risk of a decline of the neurological system with depression. So just a sample documentation of those tests would be full range of motion without pain in all joints and spine, no joint deformities, warmth or swelling, erect posture, spine is midline with expected cervical, thoracic, and lumbar curvatures, no scoliosis, muscle strength equal and strong bilaterally. And that is the musculoskeletal and neurological system. Neurological system also goes into the cranial nerve functions. I'm going to do that in a separate video.